My friends, today we will see two short yet simple topics. They are transposition of great arteries and truncus arteriosus. Okay. First of all, whether this is a cyanotic heart disease or acyanotic heart disease. It should come under cyanotic heart diseases because it will cause cyanosis. These both diseases will produce cyanosis in a sufferer. Let's go to our topic now. So, transposition of great arteries. What is the pathophysiology behind this? Let me explain you in a simple diagram. So, suppose consider this as the heart. We have 4 chambers and we have the left side, right side. Now, what is the defect in transposition of great arteries? Generally, from the right ventricle, what will arise? Pulmonary trunk, and from the left ventricle, aorta will arise. But here in this condition, from the right ventricle, aorta arises, and from the left ventricle, pulmonary trunk arises. As you can see, the pulmonary artery and the aorta get interchanged. The position of them got interchanged, leading to the arising of aorta from the right ventricle and arising of pulmonary trunk from the left ventricle. Okay. Now, this aorta which is arising from the right ventricle, it will circulate throughout the body and comes back through the superior vena cava and inferior vena cava into the right atrium. That means all the deoxygenated blood is circulating throughout the body. This produces cyanosis. Okay. Whereas the pulmonary trunk which arises from the left ventricle, it will travel through the lungs. It will travel through the lungs and then comes back to the left atrium with the help of pulmonary veins. Okay. So, the oxygenated blood is circulating in the pulmonary circuit, whereas deoxygenated blood is circulating in the systemic circuit. Here you can see the blood in the systemic circulation is not mixing with the blood in the pulmonary circulation. That means the systemic circulation and the pulmonary circulation are running independently of each other. The pulmonary circulation and the systemic circulation got separated from each other. They are running independently. That is, parallel circulation is created. Okay. This is the main pathophysiology in case of transposition of great arteries, in which deoxygenated blood is circulating throughout the systemic circuit and the oxygenated blood is circulating in the pulmonary circuit. Got it? So, next, let's have a short recap now. Here the pulmonary trunk and the aorta gets interchanged, the same thing, and that leads to systemic and pulmonary circulation getting separated from each other and they run independent of each other. Okay, this is the pathophysiology which you should know. Now, what will be the clinical feature? Severe cyanosis will be present since birth. Obviously, the deoxygenated blood is circulating throughout the systemic circuit and the blood does not carry oxygen to the tissues, right? So, that causes cyanosis. And one more thing, all the blood coming from the systemic circuit is going to cause burden in the right ventricle. That causes hypertrophy of the right ventricle, whereas the pulmonary circuit circulation is less. The blood in the pulmonary circuit is less compared to the systemic circulation. So, it leads to atrophy of the left ventricle. Okay. And coming to the treatment part, PG infusion. Remember, there will be presence of ductus arteriosus during intrauterine life. Let me show this here. Suppose this is the aorta. In case of PGA, there is transposition of great arteries. We have aorta coming from the right ventricle and the pulmonary trunk coming from the left ventricle, right? And you have the ductus arteriosus. This is aorta here and this is pulmonary trunk here. So, in the intrauterine life, this ductus arteriosus will be present connecting between the pulmonary artery and the aorta. After birth, this ductus arteriosus gets obliterated usually, but we are giving prostaglandin E to maintain the patency of this ductus arteriosus after birth. Then what happens? Some of the oxygenated blood which is running in this pulmonary circuit will traverse via this ductus arteriosus into the aorta. That means we are allowing that oxygenated blood to flow into the systemic circulation from the pulmonary circulation. That means we are connecting a channel by which the pulmonary circulation and the systemic circulation gets merged. Okay. So, by this the cyanosis part will get reduced eventually. Okay. Even though it will not produce significant improvement in the child, but a little bit improvement in the child can be seen. Now, this is the first option of treatment, that is PGE infusion. What is the second option? There is something called Rashkind atrial septostomy. What does it mean? You can see here, this is the aorta and this is the pulmonary trunk, right? And what you are doing here is you are creating a hole, that is you are creating potential gap in the atrial septum. Okay, now what happens? Through this septum, the oxygenated blood in the left atrium will traverse via this hole, that is potential gap, into the right atrium, then to the right ventricle. Through the aorta it passes to the circulation, that is systemic circulation. By this technique you are creating a potential gap in the atrium which allows the blood from the left atrium to flow into the right atrium, that is pulmonary circulation and systemic circulation is merged here. Okay, so now coming to our second part, that is truncus arteriosus. What does it mean? See, generally you know that we have the left side of the heart, right side of the heart, and atrial septum and the ventricular septum develops, leading to the separation of atria and the ventricles respectively. And then pulmonary artery, there will be a structure called truncus. This structure will usually divide into pulmonary artery and aorta during the intrauterine life. Okay, so if the truncus fails to divide, then what happens? A single vessel will arise. Okay, a single vessel will arise. As you can see here, this is the single vessel which is arising. This means this is the truncus. This is the truncus which fails to divide. So at the initial part you can see the truncus is not able to divide. So a single vessel is arising and it will be associated with VSD, ventricular septal defect. As it is associated with VSD, the blood in the left atrium, that is the oxygenated blood, and the blood in the right ventricle, which is deoxygenated blood, gets mixed up. As this gets mixed up, the mixed up blood will flow through this truncus arteriosus, and following a certain distance it divides into pulmonary and the aorta. Okay, like this. So what happens here? The main key concept here is both the oxygenated blood and the deoxygenated blood gets mixed up in the single cavity. Due to VSD, the left ventricle and right ventricle is converted into a single cavity, and from that cavity a single vessel arises, that is called as truncus. Okay, this leads to the mixture of oxygenated and deoxygenated blood, causing cyanosis. Truncus fails to divide during the embryonic life. It persists there, leading to the formation of truncus arteriosus, and single vessel arises which is associated with VSD. These both features should be generally present to cause the truncus arteriosus. Okay, now coming to the cyanosis part, here also there will be cyanosis since birth. And the treatment part, generally what is the treatment? There is a VSD, there is a single vessel, so you will close that VSD, ventricular septal defect, with the help of Dacron patch or something, and you will divide the trunk into pulmonary artery and aorta from the initial portion, right? So this procedure has a special name called Rastelli procedure. Okay, so with this we had seen these two conditions, that is truncus arteriosus and transposition of great arteries. These two are categorized under cyanotic heart diseases. Okay, because cyanosis is a characteristic feature of both these conditions. So with this, let us conclude our session. Thank you so much.